Hi, I'm Ed Stapleton. Welcome to the program Pre-Hospital Resuscitation for the 21st Century. Stony Brook has been working very hard in the last year to improve sudden cardiac arrest outcomes. We have built infrastructure, trained staff, and improved response to sudden cardiac arrest events. Numerous innovative strategies have been brought to the patient's bedside, including cerebral oximetry, use of mechanical CPR, expanded use of ultrasound to identify underlying causes of cardiac arrest, and monitoring of coronary perfusion pressures during resuscitation efforts. Many of these strategies will be discussed during this program. However, we realize that improving cardiac arrest outcomes is dependent on the quality of the system from the point of collapse, EMS care, emergency department and intensive care, acute coronary interventions, and post-resuscitation care. In this regard, we want to partner with our local EMS services to assure each patient the best possible chance for survival. During this program, we will emphasize the importance of optimizing perfusion through the use of monitoring, minimal interruption of quality chest compressions, and controlled ventilation. To start the program, let's watch an EMS team from arrival through post-resuscitation care with emphasis on quality chest compressions and minimal interruption of CPR.
At the start of the code, the team members should assume a position around the patient to facilitate their respective roles. In this event, the team leader secures a history from bystanders, indicating that the patient had chest pain and suddenly collapsed prior to their arrival. Cardiac arrest is confirmed, and manual chest compressions are started by the team leader. Compressions are 2 inches deep at a rate of at least 100 per minute, with complete release to assure adequate venous return. The airway ventilation provider integrates rescue breaths with a bag mask after 30 compressions. The circulation provider immediately attaches the monitored defibrillation pads, and the patient's rhythm is confirmed as ventricular fibrillation. Chest compressions are resumed, the defibrillator is fully charged, CPR is stopped, the patient is cleared, and a shock is delivered. Defibrillation should be performed with minimal interruption of CPR. Following the defibrillation, the circulation provider prepares the CPR compression device and, with help of the other team members, places the board under the patient with minimal interruption to chest compressions. The piston is then carefully positioned in the appropriate location on the sternum, and compressions are started using the device. Again, this is done with minimal interruption in the compression cycle. If no compression device is available, compression should be rotated every 2 minutes. Immediately after attaching the CPR device, an IV should be started and 1 milligram of epinephrine should be administered to the patient. If IV access is not possible, an intraosseous needle should be inserted as an alternative to IV access. After, the rhythm is reevaluated with minimal interruption of CPR. In this case, the patient is still in ventricular fibrillation. CPR is restarted, the defibrillator is charged, and a shock is delivered at the appropriate energy level, specific to the device being used. CPR is restarted, and 300 milligrams of amiodarone is delivered IV push, followed by a flush.
I'll take over ventilating while you prepare for the intubation.
The team leader directs the airway provider to insert an endotracheal tube to facilitate the use of continuous compression CPR. Primary confirmation is quickly performed using auscultation with minimal interruption of CPR. The ITD and end-tidal CO2 connector is attached to the endotracheal tube, and secondary confirmation with end-tidal CO2 confirms placement.
We have an opening end-tidal 15, good waveform, good plateau.
Thereafter, carbon dioxide is monitored to assure continued placement and as a guide for chest compression quality. Once intubated, the airway provider instituted a ventilation rate of 8 to 10 breaths per minute to avoid hyperventilation that results in reduced venous return. This can be guided by the light on the ITD.
It's been 2 minutes, getting ready for a pulse check.
2 minutes of CPR is performed, and the pulse and rhythm is checked. The patient is still in ventricular fibrillation. CPR is restarted, the defibrillator is charged, and the patient cleared and shocked using 200 joules.
Charge delivered. Back into continuous compressions.
With the addition of end-tidal CO2 monitoring, values should be observed to guide the resuscitation effort.
Okay, we have good waveform capnography.
The good waveform capnography is increasing to about 20. That's still good plateauing.
Excellent.
A sudden rise in end-tidal CO2 may indicate a return of spontaneous circulation. Values less than 10 millimeters of mercury may indicate poor compression performance.
Okay, we're at 2 minutes.
The team leader and other team members
Okay.
should keep a close eye on the monitor. A second dose of epinephrine or a dose of vasopressin should be administered.
Okay, we've got 2 minutes, so let's pause the monitor and do a rhythm check. We still have VFib. Okay.
Again, after 2 minutes, the rhythm is checked. The patient is in ventricular fibrillation. CPR is restarted, the defibrillator is charged, and the patient cleared and shocked using 200 joules. Compressions are continued.
Okay. Keep ventilating. Why don't we draw up 150 of amio?
At this point, a second dose of amiodarone should be administered, followed by an IV flush. After 2 minutes, the rhythm is checked again. A sinus rhythm of 120 is observed, and a pulse is noted. The patient's respirations are checked, and the patient is determined to be in respiratory arrest. The team leader orders ventilations at a rate of 1 breath every 5 to 6 seconds and advises monitoring and adjusting oxygen saturation to achieve a saturation of 94 to 96%.
Patient's blood pressure is 94/50.
Okay, he's a little bit hypotensive. Let's initiate the hypothermia protocol.
The blood pressure is taken. A reading of 94/50 is noted. The team leader orders cold saline to begin therapeutic hypothermia and ice packs to be placed in the neck, armpits, and groin. The patient is then prepared for transfer to the hospital for continued care and monitoring.
He's still not breathing.
Okay, let's review the key management steps presented in this video. The team confirmed cardiac arrest and immediately started manual compressions. From this point forward, quality compressions are the most critical aspect of the resuscitative effort. The team leader and circulation provider should continually monitor the end-tidal CO2 and adjust compression as needed. Special care should be taken when transferring the patient to make sure that quality does not decrease. Ventilation was managed with an advanced airway device to establish continuous compression CPR and maximize cardiac output. The ventilation rate was maintained at 8 to 10 breaths per minute to avoid hyperventilation. Throughout the code, compressions were interrupted for very short periods of time to assure continued perfusion. Team members communicated seamlessly to update the team leader on the progress of the resuscitation effort. When the patient was resuscitated, ventilation was managed by bag mask in order to maintain oxygen saturation between 94 to 96%. Thank you for spending time with us today. We look forward to partnering with you to improve cardiac arrest survival rates in Suffolk County.